Hi, everyone. Welcome to the Neurocritical Care Society podcast. My name is Lauren Koffman. I'm a neurointensivist recording this from Chicago, Illinois. And today I'd like to welcome Jeff Barletta. He's a professor and vice chair of pharmacy practice at Midwestern University, College of Pharmacy, and a clinical pharmacy specialist at Honor Health, John C. Lincoln Medical Center in Phoenix, Arizona. He's recognized as a fellow in the American College of Critical Care Medicine, a member of Council for the Society of Critical Care Medicine, and a member of the American Board of Internal Medicine Critical Care Medicine Specialty Board. I'd like to welcome him here today. He is the first author on a paper that was published in Neurocritical Care back in October of 2020, entitled The Role of Desmopressin on Hematoma Expansion in Patients with Mild Traumatic Brain Injury Prescribed Pre-Injury Antiplatelet Medications. How are you doing today?
I'm doing fine. Thank you for having me.
Well, we're happy to have you here. The whole purpose or study of this paper was to evaluate the effect of DDAVP in mild TBI patients. So I thought maybe we could just start off by discussing what DDAVP is, how does it work, and how do people traditionally think about it in terms of managing bleeding or coagulopathy?
Sure. Well, antiplatelet medications are widely used in patients with cardiovascular disease, and their benefits are well noted. But unfortunately, these medications can be problematic in the setting of major trauma or injury, and particularly those patients with traumatic brain injury. DDAVP is one agent that makes sense, at least mechanistically, in this setting, in my opinion. Through its effects on von Willebrand factor and factor VIII, it can promote platelet adhesion and aggregation, and potentially minimize adverse outcomes secondary to bleeding and hematoma expansion. When we look at the literature, though, most of the data in this setting originate from studies that measure platelet activity via platelet function tests, right? There are limited clinical data evaluating either clinical outcomes or radiographic outcomes. So at our institution, we started using DDAVP around maybe late 2014, early 2015 for this indication. So our objectives with this paper were to describe our experience and report some data describing the efficacy and safety of DDAVP.
And great. And speaking of safety, when you were evaluating that, what were the main adverse events you were monitoring for?
We were primarily focused on thrombotic complications.
So now in terms of the methods, you guys are a level 1 trauma center and you kind of retrospectively identified patients over a 6-year period. Is that right?
Correct, yes.
Now, what I thought was interesting was you grouped patients in those that received DDAVP and those that didn't. And it seems like there had been an institutional protocol developed during that time. Would you mind just kind of talking a little bit about that, how it happened?
Right. So, like I said, we started using DDAVP routinely in all of the patients with TBI who were identified to have been prescribed or taking any antiplatelet medication. So, we wanted to do somewhat of a pre-post type analysis to see the benefit of DDAVP and the safety as well. And we thought that these data could potentially help justify a randomized controlled trial or something on a larger scale to really evaluate the role of DDAVP in a real world setting.
And just a question about the dosing. I believe you used 0.3 mics per kilogram. Is that right?
Yeah, 0.3 mics per kilo IV.
And just a question, I know this was done going back several years, but the guidelines now, I believe from 2016, state 0.4. Can you just discuss what your rationale is in choosing that dose?
We started using 0.3 primarily based on data in the hemophilia population. And when you look at different guidelines and different doses that were used in the literature, it seems to gravitate either between 0.3 or 0.4. Initially we chose 0.3. I think based on some of our results and our findings on this study, I have some theories regarding the efficacy in different populations, particularly those patients taking different antiplatelet medications or perhaps based on aspirin dose, where 0.4, may be a more appropriate dose. We have started using 0.4 per kilo in our population now, and largely based on some of these findings, which I'd be happy to go over.
Okay, great. And one other question I had, did you consider when you were looking at patient demographics, any comorbidities that could have contributed to some coagulopathy, such as CKD or kidney disease?
Yeah, we evaluated comorbidities, like CKD, cirrhosis, liver failure. We also focused on other medications that patients may have been taking, like anticoagulants and other confounders that could potentially influence our findings and impact hematoma expansion.
And why don't you go ahead and share with us what you found in the study?
Sure. I'll start with just going over our methods. Again, this was a retrospective cohort study, and we wanted to take more of a pragmatic approach to studying DDAVP to really get that real world look at both efficacy and safety. So patients with radiographic evidence of TBI who were taking antiplatelet medications pre-injury were identified, and then we stratified them into two groups based on whether or not they received DDAVP. Our primary outcome was hematoma expansion, which we defined as a 20% increase from baseline or a new hematoma that wasn't present on the initial CT scan. And then we also reported hematoma expansion using a threshold of 33% as more of a secondary measure, just to see the robustness of the data. And then for safety, like I said earlier, we evaluated thrombotic complications that occurred within the first 48 hours. So for our analysis, we used univariate and multivariate statistics to control for confounders and identify predictors for hematoma expansion. And I think one thing that's unique with our study is the use of classification and regression tree analysis, or CART, to create decision trees. And if you're not familiar with CART, I think it's a useful technique that can take continuous data and then identify a threshold to form mutually exclusive groups based on that natural breakpoint in the data. So it nicely displays the interaction between different confounders or variables, and the results are displayed as a decision tree versus an odds ratio. And this is really the way I think we practice at the bedside, right? We think in terms of algorithms and decision trees and treatment and our treatment approaches, versus just taking an odds ratio. So I thought that was somewhat unique, and it really it gave us some interesting data that I think are hypothesis generating.
And so was there any particular reason why you chose, or why the group chose to take that approach?
When you do a multivariate analysis and you have your predictors, you see each of those factors as an independent predictor, but you really don't see the interplay between those variables. And this is a technique to help identify some subgroups where the drug may be more beneficial than, say, in other settings. And that's the way I always like to look at it. The treatment approach was most highly recognized in this subgroup, as opposed to the alternative where you would say, well, it didn't work in the alternative group. I don't think we can necessarily say that. So again, I think it is hypothesis generating for future studies.
So it seems like when you guys took a look at your results, you had a pretty large study, fairly large considering the smaller studies that have been done in this patient population in the past that have received DDAVP. It was 202 patients, and 78% had received the DDAVP. Is that right?
That's correct.
Yeah. And when you looked at the different categories of mechanisms of injury, the largest proportion were falls, which were 76%. And then subdural hematomas were the primary intracranial brain injury, making up 69%. Is there any reason why you chose to focus on just the mild TBI?
That's just the way that the data turned out. I think we were, surprised to see that most of our patients did present with an initial GCS in the mild category, between 13 and 15. But that being said, a lot of those patients still had hematoma expansion. So even though these patients came in with mild brain injury, some of them did progress to more moderate or severe.
And when you looked at the hematoma expansion, which you described as 20% or more, or new hemorrhage, you found that it was 14% incidence in the DDAVP group and 30 in the no DDAVP group, which was statistically significant. What I wanted to ask was, there's this, significant decrease in hematoma expansion. But when you look at the amount of hematoma expansion calculated in mLs, it was actually larger in the DDAVP group. I didn't know if you had any thoughts about that.
Yeah, we wanted to see if DDAVP would reduce the percentage of patients with hematoma expansion. And we also wanted to see if DDAVP influenced the extent of that expansion. And unfortunately, we didn't find that with DDAVP. It was primarily more of the former than the latter. So again, it's another area for future study to see if DDAVP or any other intervention could assist with that outcome.
And do you want to describe to the listeners what particular group seemed to be the best responder to this treatment?
Yeah, so, when we did our analysis, we did our univariate analysis and then our multivariate analysis. And the way that we built our multivariate model, we used the results from the univariate analysis along with some variables that we felt were clinically important versus statistically important. And those variables we forced into the model. So for example, the use of oral anticoagulants and platelet transfusions. And then when we ran our analysis, our final model identified the following risk factors for expansion, which were age, high dose aspirin, multi-compartmental injury, and then we found that DDAVP was protective. So our CART analysis revealed that DDAVP was most effective in patients who received low-dose aspirin, had a single type of head injury, so for example, a subdural versus both a subdural and a subarachnoid, and then patients who were age 86 years of age or lower. And, I think when you think about these subgroups, it makes sense that DDAVP was most effective in patients who received low dose aspirin. And I have my theories as to why that may be, and we can talk about those. Patients who had a single type of head injury, so perhaps reflecting severity of injury, and then age.
And would you want to briefly go into what your thoughts are as to why that particular low dose aspirin group had those results?
Yeah, it can be one of two things. The first could be perhaps we were just underpowered to detect a difference in some of those other subgroups. And, as you know, when you start dicing and slicing your data and you lower your sample size, it's harder to detect a significant difference. And, I hate to use the word trend, right? But when you look at some of the trends in some of the other categories, perhaps that p-value would flip with more data, with more patients. But, we would need additional studies to determine that. The other theory could be related to dose. And, we talked earlier about the dose 0.3 versus 0.4. And, I wonder if using a higher dose may be effective in patients who take a higher dose of aspirin, or perhaps, patients on dual therapy. And again, we would need future dose ranging studies to determine that. And unfortunately, there really aren't those types of studies in this population. There's some literature in the hemophilia population that suggests maybe there's a dose-related response with DDAVP, but again, in this setting, there really are no data. So that's certainly something in the future that I would like to see to really pinpoint what the best dose is. And maybe we need to take an individualized approach with dosing depending on what particular regimen patients are admitted with.
That's really interesting. I think another important thing we just might want to throw out there is that you found no differences in the thrombotic events. Is that correct?
That's correct.
So essentially, there were minimal to no risk in giving this dose.
I hate to say no risk, right? Because everything has risk, but, we were unable to identify any increase in thrombotic complications. And I think when you look at other studies, that finding is consistent. So I feel comfortable that this intervention is safe, at least based on our experience and other people's experiences as well.
And I didn't notice, or maybe I missed it, was the timing of DDAVP recorded, or is there a certain threshold that it was given from a time of admission?
Yeah, so the the time to DDAVP administration in our study, and this is the time from when patients were registered in the ED to when it was actually administered and charted on the EMAR, was about 3 hours. So, obviously we try and administer this drug as soon as possible. And as soon as we identify that patients are on antiplatelet medications, the medication gets administered quite quickly. But, the rate limiting step here, I think, is identifying those patients who are actually on antiplatelet medications. And, our neurocritical care team and our pharmacy teams do a fantastic job doing med histories and asking the right questions and digging through the EMAR. But, sometimes patients simply don't know what they take, or they're not in a frame of mind to really report that. So, we do further investigating by calling pharmacies and trying to identify the exact regimen that patients are on as quickly as possible. But that's not possible at all hours of the night. So I think that's what tended to pull up that time of 3 hours. But obviously we want to administer the medication as quickly as possible.
Now that you're using the higher dose, are there any plans to do a follow-up analysis or study?
Yeah, I would like to look at the effectiveness in different populations. So patients who are on low dose aspirin versus high dose aspirin versus, clopidogrel or other agents or dual antiplatelet therapy. So yeah, I think that's certainly an area for future research.
So if you wanted the listeners to have one key takeaway point, what would you want that to be?
I think I would want that to be that, DDAVP is a useful intervention in this setting, and that it's also safe. And I think these data, along with other recently published manuscripts, do justify a randomized controlled trial or something on a larger scale. There are, some unanswered questions, I think, that certainly is an opportunity for additional research, particularly, which patients would benefit the most. Is the benefit equally recognized across all of these different patient subgroups and different antiplatelet medications? And then finally, what's the most effective dose?
Yeah, there's a lot of opportunities out there to kind of better identify which groups might benefit best. Well, I appreciate you for joining us today. Thank you so much.
Thank you. This was really fun. And, of course, I'd like to acknowledge my research team on this paper, Dr. Victor Zach, who leads our neurocritical care team, and Dr. Alicia Mangrum, who's our chief of trauma and, research and critical care for that matter. It's a team sport. So I'm fortunate to have some great colleagues to work with.
Awesome. We can't wait to see the next paper that comes out.
Thank you very much.
Thanks for listening to the NCS podcast. The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. Our production staff includes Tariq El-Maghribi, Andrew Barishmet, Leonid Groisman, Atul Kalanuria, Lauren Koffman, Cassie Cronfield, Holly Ledyard, Lindsay Marchetti, Alexander Reynolds, Lucia Rivera-Lara, John Rosenberg, Jason Siegel, Zachary Threkel, Teddy Yoon, and Chris Zaman. Our administrative staff and senior producer is Bronnie Rousseau. Music by Mohan Kadapali from the University of Miami Division of Neurocritical Care. If you like our show and want to learn more about us, check us out on Twitter, Facebook, or LinkedIn. The NCS podcast is available on NCS On Demand, iTunes, and wherever you get your podcasts. I'm Fawaz Al-Mufti, and thanks for listening.